Good evening, everyone. Welcome to another Friday episode on Experts Appraisal in Emergency Medicine in association with ANBI and SEMI. It's my pleasure to have you all join us for this insightful and engaging session. I am Dr. Pranay, MD Emergency Medicine, and I will be the moderator for today's session. So today's topic of discussion is beyond fixed ratios, goal-directed massive transfusion. Massive transfusion is something that an emergency physician does probably on a regular basis, on a daily basis, in patients of trauma, obstetric hemorrhage, GI hemorrhage. The conventional thinking usually is when we activate massive transfusion protocol, it's 1:1:1 ratio of packed cells, FFP, and platelets. But sometimes patients may require more of certain blood products, and it's not only 1:1:1 ratio. It may require more of certain blood products. So today's topic will focus on advancing our understanding of transfusion strategies in both critical care setting and emergency medicine setting. So today's session will be led by Dr. Isha Polavarpu. She's a consultant in transfusion medicine and transplant immunology in Yashoda Hospitals, High-Tech City, with over 5 years of experience in this field of transfusion medicine. She has completed her MD in IHBT from the Kasturba Medical College, Manipal, and her areas of interest include therapeutic apheresis, peripheral blood stem cells, transplant immunology, and advanced immunohematological workup. She has also been awarded the Postgraduate Student of the Year Award in 2019 from ISTM, and also the Best Research Presentation in the 68th IGCLA conference in Manipal on the topic of red cell alloimmunization among thalassemia patients. She has also done an interesting project in identifying rare blood donors in Udupi district of southern Karnataka. And she also has many numerous publications in national and international journals. And over to you, ma'am.
Hi. Thank you, Dr. Pranay. I think I'll just share my slides. Right. Is this okay? Can see? Everyone can see?
Yes, ma'am.
Yeah. Hi. Good evening, everyone. So today I'll be talking briefly about goal-directed massive transfusion strategies in an ER perspective. So this is an overview of the topics that are going to be covered today. So the first thing that comes to my mind when an MTP is activated, sorry about the font, somehow it just got changed when I'm loading in this system. So the first thing that comes to my mind when an MTP is activated is this lethal triad. Now along with hypocalcemia, the lethal diamond. So I'm going to discuss how we can contribute from a transfusion perspective in all of these things. First is obviously the coagulopathy. So in coagulopathy, we either give a fixed ratio based transfusion or a goal based transfusion support. And second, in acidosis. So what happens in acidosis? I try and give fresh units for trauma hemorrhage as much as possible, because your older units, they have one potassium and they also have a, some bit of hemolysis. So since we are not talking about 1 unit or 2 units, say we will be giving around 6 to 8 units, sometimes 10 units. So all of these will increase the hydrogen ion concentration in the patient and will contribute to this acidosis or worsen it. And then next, hypothermia, blood warming is completely required in these cases. And also in the case of hypothermia, your conventional coagulation tests may not give you a true picture because they're usually performed at 37 degrees. So that is something to keep in mind. And coming to hypocalcemia, unfortunately, the blood products that I give you that will cause hypocalcemia, whether it is your PRBC or your FFP, because that will have citrate. So citrate is an anticoagulant, and your citrate will chelate the ionized calcium and decrease the calcium levels. So that will contribute to hypocalcemia. So from the ER end, calcium supplementation in an MTP is very essential. Next, coming to the definition, very briefly, first is the classic, the very old definition, transfusion of more than 10 units of PRBC in 24 hours. This has come up in a combat setting, not in a civilian setting. Now, transfusing more than 3 to 4 units of PRBC in 1 hour with anticipation of continued need for blood support. This is more practical and useful in a civilian setting. Also, replacement of more than 50% of total blood volume with blood products in 3 hours, and then bleeding of more than 150 ml per minute. So there are also different definitions for pediatric massive transfusions as well. So coming to the key points in designing an MTP. So individual hospital protocols are better, hence there are no standard guidelines. So we have to estimate the need and type of the patient population. For example, if we are a hospital which primarily caters to mother and child, so we have only obstetric services, we need to have an MTP which will concentrate on PPH. So if we are a hospital which is only dealing with CTVS surgeries, then we need to design an MTP which will support cardiac surgeries. Or since our hospital is situated on a highway, so we have a trauma-based MTP. So we need to design an MTP based on the patient population which will come into the hospital. Then always keep a 1:1:1 ratio of transfused components. Develop quality indicators and do a regular audit of the MTP. Next is design a process flow which should be universal throughout the hospital. So in an MTP process flow, what is important? First is initiation. So when and who will initiate the MTP? And second one is communication, that is notifying your blood center, notifying your lab. Then third one is a lab testing algorithm. So what what algorithm will you ask the lab to test, whether it is a conventional based algorithm, goal based algorithm? So that needs to be uh, clearly defined. And third one is the preparation and delivery of the blood itself. So we need to have some predetermined packs or boxes that should be given to the clinician easily. And then yes, and there are certain policies which are important. First one is RHD switching. So you should remember that O negative is a finite resource and we don't have enough to give for every MTP case. So unless it is a female within the childbearing age group, RHD switching to ORHD positive blood group is acceptable, but we should have a policy for it with prior discussion with the emergency medicine physician or the clinician in charge of the case. Then administering antigen positive units to patients with alloantibody or incompatible cross matches. This is especially important in a center like ours where we have a lot of hematology cases who are transfusion dependent cases who will have antibodies like say your Duffy A antibody, JKA antibody, anti-capital M, anti-capital S, and all of these patients might land up in ER at some point. So we will not be able to give you the correct antigen negative units for those antibodies in a short period of time. So we should have a policy to administer antigen positive units if the patient is bleeding profusely. And incompatible cross matches, where do we have this? In your IHA cases. So with a very strong hemat unit, you will have frequent IHA cases in the ER and you will have to end up giving least incompatible units. You can't wait for the complete cross match AG phase cross match compatible units. That's not possible in a bleeding case. And we should also have SOPs for patient identification and emergency issues. So in this process flow of MTP, we have to start giving 1:1:1 ratio empirically to maintain hemostatic balance. For example, 4 units of PRBC, 4 units of FFP, and one full adult dose of RDP, or that is 6 units of RDP or 1 unit of SDP, and 10 units of cryo. So your cryo dosage is 1 unit of cryo for every 7 kilos. So replace all units proportionally. This is to mimic the whole blood See, when we talk about 1:1:1, it is not the number. So it is not just one PRBC, one FFP, and one RDP. No, it is a proportion. So it is, say, 4 units of PRBC, 4 units of FFP, and one full adult dose of RDP. That is 6 units. That is how we have to replace. So, what are the expectations from transfusion medicine in an MTP from the ER? One is prompt blood product release, that is, issuing your PRBC, FFP platelets, and cryoprecipitates rapidly without repeated requests or paperwork delays. And second one is proactive communication. So, what usually happens when an MTP is activated, this we have seen here as well, the nurse calls the technician in charge or the technician on duty. So the technician cannot issue any product without doing the proper documentation, without making a label. So what is important is for the consultant, even if it is not the senior most, the junior consultant should call one of us on the lab end, on the blood bank end. So we will be able to resolve the logistic issue. So I can give you blood without documentation. It is just that I need to be there, not the technician. And second one, providing timely coagulation parameters and TEG or ROTEM results. This is to guide your goal-directed component therapy and which will reduce the overtransfusion, which will reduce the multi-organ failure and improve the outcomes. Then we have to maintain enough inventory. At least 2 to 3 units of emergency O negative units should be maintained for ER massive transfusion cases. And then documentation and hemovigilance. So, how to predict the need for massive transfusion? There is your shock index, your ABC score, your TASH score, Rayner score. So, this I have just added this slide. This is completely a clinician point of view, ER physician point of view. So, when to activate and when to stop MTP? This again is a clinical decision. But in when to stop MTP, let us just look at the lab parameters. So, we can stop MTP when hemoglobin is more than 7 gram per DL, when platelets are more than 50,000, when PT is normal or less than 1.2 times of normal, and when your fibrinogen is more than 150 mg per DL. So, coming to TIC, that is your trauma induced coagulopathy pathophysiology. So, what happens in a trauma? There is a hemorrhage, obviously. This will result in hypoperfusion and increase in your platelet activated protein C levels and decrease in the clotting factor activity. And second most important thing that will happen in a trauma is your endothelial damage. So what happens when endothelium gets damaged? Your thrombomodulin releases, your thromboxane A2 releases, your tissue plasminogen activator releases, your plasminogen activator inhibitor also releases, your nitric oxide releases. So all of these release and this will lead to autoheparinization and dilution of the blood itself. This will result in decrease in clotting factor activity. There's also platelet activation in trauma, which will lead to platelet dysfunction. And next most important thing that can happen here is your hypofibrinolysis. So this happens because, or this is triggered by severe shock. So this triggers a massive release of your tissue plasminogen activator and decrease in the plasminogen activator inhibitor. So this will cause decrease in clotting factor activity and hypofibrinolysis. All of this will contribute to clinical coagulopathic bleeding. So what happens in hypofibrinolysis? Your body goes on dissolving the clots as soon as they are formed. That is why hypofibrinolysis. Then also one more thing, an iatrogenic resuscitation injury can happen. So what can happen is a dilutional coagulopathy. So if more amount of IV fluids is given or just PRBC and IV fluids is given, that will dilute out the remaining clotting factors and platelets and it will also cause increase in acidosis and hypothermia. This will also contribute to the coagulopathic bleeding itself. This is also the rationale behind why we started giving platelets and plasma early on in the transfusion support instead of just giving PRBC and IV fluids. So, starting with the proper trial. So this is a landmark trial in trauma. So what they did is they compared the transfusion of plasma, platelets, and red cells in a 1:1:1 versus 1:1:2 ratio, and they noticed that there was no significant difference in mortality at 24 hours or at 30 days. However, more patients in 1:1:1 group achieved hemostasis and fewer experienced death due to exsanguination by 24 hours. So, this was published in 2015. So, after 2015, there were a lot of sub studies of proper trial as well. And one of those studies was early platelet transfusion. So they did a study where they just studied patients who were given platelets early on, that is within the first box itself. And they noticed the patients who were given platelets early on, they achieved hemostasis early, and there was a proper reduction in mortality in those cases as well. Then again, one more study, which is a follow-up of proper trial, which was done in 2019, which showed that there is earlier time to hemostasis is associated with decreased mortality and rate of complications. So this is a study which showed the impact of plasma transfusion in trauma patients who do not require massive transfusion. So for these non-massively transfused trauma patients, just giving FFP has been associated with a substantial increase in complications, particularly your ARDS, MODS, pneumonia, and sepsis. You can also see that the in-hospital mortality rate, overall complication rate, and ARDS was higher in patients receiving plasma compared to patients who are not receiving plasma. Then again, what are the issues with plasma transfusion? We all know it is notorious for causing transfusion related acute lung injury and transfusion associated circulatory overload. Next, just briefly about your conventional coagulation tests. One is your PT and APTT testing methods. So what happens here? Your plasma, that is your platelet poor plasma after collection in a citrate tube, is incubated with your thromboplastin, your calcium, phospholipids, and it is incubated at 37 degrees for about 3 minutes. And then the time taken for the fibrin clot to form is measured. That is your PT and your APTT. So, but what actually happens? Blood clots because thrombin generates. So, here you can see the clotting time. Plasma clots when just less than 2% of all the thrombin is formed. So, what we are seeing in PT APTT covers only 2% of thrombin. So, after this, 98% of thrombin is generated, which will form the clot. So, your maximum clot strength is formed by about 98% of thrombin, and this is completely missed out by your PT and your APTT. So, what are the differences between your ratio based and your goal directed viscoelastic testing? So, ratio based, it is fixed component ratios, typically 1:1:1. It is administered empirically to all massive transfusion patients. This is simple and protocol driven. No laboratory guidance is required, but there's a risk of overtransfusion. There's a good evidence base of proper trial and prompt trial. Now, coming to viscoelastic testing, this is TEG or ROTEM guided, and it targets specific hemostatic defects with precision component or factor replacement. So we don't blindly transfuse, we only transfuse what is required here. So it is individualized and physiology driven. It reduces unnecessary product exposure. Only drawback, it requires a TEG or ROTEM infrastructure. So what is viscoelastic testing? These are just point of care tests that allows for global assessment of coagulation using whole blood, and they measure clot initiation, clot strength, and the clot lysis. So what are the types? So one is TEG and one is ROTEM. So both of these are viscoelastic tests which are using whole blood to measure the mm, viscoelastic properties in whole blood. So in ROTEM, the cup is stationary and there's a rotational pin, And in tech, there's a rotating cup, but the pin is stationary. And so the changes are detected in a optical. Uh, there's an optical detection of these changes in the clot, and a graph is formed in ROTEM. There's an electromechanical detection and a formation of graph in tech. That is the only difference. So just starting off with ROTEM. So this is a standard rotational thromboelastometry graph. So it has different values. Let us just quickly go through what is each value. So coming with your clotting time, this is time from the beginning of the test until when an amplitude of 2 mm is achieved. So what can influence this? Your coagulation factors. If there's low coagulation factor, your CT will increase. If there is anticoagulants given, again CT will increase. Whether it is your warfarin or other anticoagulants, CT will increase. Mm. Then it clot formation time taken to reach 20 mm amplitude from the CT. The next one is your amplitude. This is important in trauma. So this is amplitude after a certain time, say 5 minutes or 10 minutes after clotting time. So your A5 is amplitude at 5 minutes, A10 is amplitude at 10 minutes. These two factors are very important in trauma, and this is mainly influenced by platelets or fibrinogen. So based on this, you can decide whether there is a platelet deficiency or a fibrinogen deficiency and what to transfuse. Next one is a maximum clot firmness. This is when there is maximum thrombin generation, maximum clot firmness. So here both platelet deficiency and fibrinogen deficiency can affect this. Next one is the lysis index. Say this is the relation of the amplitude to the maximum clot firmness 30 minutes after CT or 60 minutes after CT. And what can affect it? Fibrinolytic enzymes and fibrinolysis inhibitors. The next one is maximum lysis. This is the degree of fibrinolysis related to MCF achieved after measurement. So again, these are all the parameters in one chart, and what can affect each parameter. Most likely thing to affect each parameter. So you can see up to CT it is thrombin generation, clot strength it is your amplitude and your MCF. Fibrinolysis is measured by lysis 30 and your ml, maximum lysis. So there are several modifications of ROTEM. This is important because we need to know what to order from a ER perspective. So first one is your extem, which monitors your extrinsic pathway, and key constraint is a tissue factor. Then it is your there's a FIPTEM which monitors the clot firmness after blocking the platelet contribution. This is basically your extem plus antiplatelet agent. So then your aptem. This monitors the clot firmness after blocking hyperfibrinolysis. So this is your extem plus antifibrinolytic agent. Then there's your intem, which monitors your intrinsic pathway. Then there's your heptem. So heptem is specifically for cardiac cases. It neutralizes heparin up to 7 IU per ml. So usually used in CTVS cases. So what is important to order from a ER perspective? You need your extem and your FIPTEM. So aptem is basically a confirmatory test for hyperfibrinolysis. So you notice a hyperfibrinolysis in your extem and then you do an aptem. If the aptem becomes normal because it has an antifibrinolytic agent, your hyperfibrinolysis gets confirmed and you can proceed with your tranexamic acid. So these three are very important from a ER perspective. Next comes your TEG. So this is a normal TEG graph, that is thromboelastograph. So the parameters are slightly different. So there is R time, which measures the clotting time. Then there is your K value and the alpha angle, which measures the clot kinetics. So again, alpha angle again is also dependent on your platelets and your fibrinogen. Then the MCF in ROTEM is called MA in TEG, that is maximum amplitude or maximum strength of the clot. And then your lysis parameters, which is LY30, that is at lysis at 30 minutes and lysis at 60 minutes, LY60. So just briefly, your PT APTT just measures up to the clot formation. So that is your R time. And clotting factors will affect your R time. Then your clot kinetics, K time, and alpha angle. Again, this is affected by both fibrinogen and platelets. Clot strength, again, platelets and fibrinogen play a role. And lysis 30 and 60. This measures the fibrinolytic activity. And it will tell you whether it is primary fibrinolysis or secondary fibrinolysis. So this chart is just to tell you that there are normal values of TEG and ROTEM. This will be given to you by the company, or the better thing would be to derive your own values for your population. So you take 30 males, 30 females, you just do a TEG and or ROTEM, whichever is available for your patients, and you derive your own normal values. That will be more accurate. Next one. Coming to the functional definition and characterization of acute traumatic coagulopathy. So, acute traumatic coagulopathy is functional and characterized by reduction in clot strength. So, you're looking at a clot amplitude. So, when I'm talking about A5, I already explained amplitude at 5 minutes. So, here they're mentioning it as CA5. This is the same thing. So, it is clot amplitude at 5 minutes of less than or equal to 35 millimeters on an extreme can identify acute traumatic coagulopathy at 5 minutes, and it also predicts the need for massive transfusion. So if A5 on your extreme is less than 35, you can almost predict your need for massive transfusion. And you get that information at 5 minutes. So next one, yeah. So coming here, you can see that in the second graph, please look at the A35. So, sorry, A5, if it is less than 35 mm, there is a massive transfusion need for both PRBC and FFP. Both the graphs show that. But if the A5 is more than 35 or normal, then avoiding platelet FFP transfusion is important because it is unnecessary and potentially harmful. And you have to treat your trauma induced coagulopathy early when the A5 is less than 35 mm. Now coming to FICTEM, FICTEM has A10, that is your amplitude of the clot at 10 minutes. So this also provides an early prediction of massive transfusion. So here what happens if you are, I think, I don't know if you can see the x-axis. So as your A10 keeps on increasing, the transfusion need decreases. If your A10 is low, then your transfusion need increases. You can see here if the A10 is between 0 to 3 mm, you have to almost transfuse between 10 to 15 units of PRBC. And if it is more than 12, then there's no need to transfuse. Here also it is always, I have to mention, avoid FFP transfusion because it's unnecessary and harmful. Again, A10 is a proper triage marker because at 10 minutes you will know whether to give fibrinogen or not. So amplitude at 10 minutes, if it is low, it is due to hypofibrinogenemia. So you have to either give your fibrinogen concentrates or your cryoprecipitate. And then there's another study, again in 2015, which again confirmed the previous findings of ROTEM CA5 as a valid marker for acute traumatic coagulopathy and a predictor for massive transfusion. So the optimal threshold in this study they quoted as extreme less than or equal to 40 mm, extreme A5, and also FICTEM A5, not A10 here like the previous study, less than or equal to 9 mm. So different studies were quoting different values of both the extreme A5 and the FICTEM A10. So there was a consensus conference in 2014 where they came up with viscoelastic test-based transfusion guidelines. So these are algorithms which will guide us in transfusing the right product. So So this is a prospective observational study for data-driven development of ROTEM and TEG algorithms in the management of trauma hemorrhage. Here, based on ROTEM, TEG, and your conventional coagulation tests, they have devised how much fibrinogen to give, how much platelet to give, how much plasma to give, and how much tranexamic acid should be given. Here you can notice in your conventional coagulation test, fibrinolysis is not measured, so trenexa component is not there. in the third column. So what they're saying, your if your victim A5 is less than 10 mm, how much fibrinogen to give? Similarly on TEG and similarly with your conventional coagulation test. There are different algorithms for different conditions given in various articles. So I've only included the trauma-induced coagulopathy algorithm here. So this is an evidence-based trauma A5 algorithm. So assess the clinical situation. If there is a need for transfusion, first treat the hypofibrinolysis. If you can recall the ROTEM graph, fibrinolysis is the last thing to get detected, but it should be the first thing to treat, because if you don't treat the fibrinolysis, whatever you give will not work. It is like you have to shut the tap basically, or because if you remember the TIC pathophysiology also, whatever clots are forming because of hypofibrinolysis, they just get dissolved. So you have to treat the fibrinolysis first. So give your tranexamic acid based on the ROTEM values here. Then your clot firmness. So look at the values, figure out whether it is a fibrinogen deficiency or your platelet deficiency. If you have fibrinogen concentrates in your ER, give fibrinogen concentrate. If you don't have, give cryoprecipitate. If there's a platelet deficiency, give your platelet concentrates. And also here they've given a very nice table. So A5 of fibrinogen, if it is more than 12, there is no problem. So how much fibrinogen concentrate to give and how much cryoprecipitate to give based on the A5 FIPTM values. Then your thrombin generation. So if this is a problem, you have to give your PCCs or FFP based on the availability. After giving all of this, if the bleeding is still ongoing, do a clinical reassessment and then take a fresh sample and do a POCT reassessment after 15 minutes. Similarly, there's a TEG algorithm as well. So if it is hemorrhagic, you can figure out whether if the R time is more than 10 minutes, you can figure out it is due to low clotting factor function. If it is greater than 10 minutes, if it's not greater than 10 minutes, based on the maximum amplitude, you can figure out whether it is a low platelet function or a low fibrinogen level. And then in hypercoagulable state, whether it is due to platelet hypercoagulability, and then fibrinolysis, whether it is due to primary fibrinolysis or secondary fibrinolysis. So this is a tech-based transfusion guideline, like we have seen ROTEM-based algorithm before. This is a tech-based algorithm. So based on the value of the tech variables, what component to give, how much component to give. So coming to the next slide. So here it is. This is a huge study which recruited around 20,000 patients and showed that in trauma-induced coagulopathy, the prevalence and association with mortality persists some 20 years later with all the advances in the trauma management. So they are saying that there is almost a prevalence of 33.4% of TIC, and that has a major impact on mortality, not just in severely bleeding cases. So they have covered all the injury severity ranges. So even if a patient is not severely bleeding, moderate bleeding, they can end up with TIC. So monitoring in the ER with a viscoelastic test is very important. Next one is your goal-based hemostatic resuscitation of TIC. So here you can see when they utilized a goal-directed and a goal-directed MTP based on TEC to resuscitate severely injured patients, this improves the survival compared to MTP guided by conventional coagulation assays. So conventional coagulation assays is the blue line and the brown line is the TEG-based assays. So you can see that the 28-day mortality is very low, 19.6 in TEG-based assays compared to 36% in the CCTs. And also they use less plasma and platelet transfusion during the early phase of resuscitation. So this is the first trial where they showed that fibrinogen in the initial resuscitation phase of severe trauma. That is, if you give fibrinogen concentrate within 12 hours compared to giving fibrinogen concentrate at 24 hours and 48 hours, this has drastically improved the fibrinogen levels in the body, and it has maintained also. So giving fibrinogen early on will help us control the TIC. So this was a recent guideline published in 2025 by the Association of Anesthetists. So patients who continue to bleed actively should be monitored by point of care or regular laboratory tests for coagulation. That is your PT, APTT, fibrinogen, platelet counts, and platelet function tests. So if you do viscoelastic testing, they have put out guidelines that say how much cryo, how much platelets, how much FFP, or even if additional tranexamic acid should be given based on the TEG or ROTEM values. So we have seen Western studies. So this is from my alma mater. From this study was published from KMC Manipal in collaboration with the ER department. So this is tailoring transfusion strategy using TEG in goal-directed massive transfusion and its impact on transfusion requirements and clinical outcome. So they included 2-year retrospective data that for a control group for patients who received massive transfusion using fixed 1:1:1 protocol, that is your group A, and they included patients in group B. These were all managed prospectively with TEG guided massive transfusion protocol. So there were 113 patients in the formula based group, group A, and there were 109 patients in the goal based transfusion group. So what they noticed at the end of the study is at the end of TEG guided transfusion, 75% of the patients were free from transfusion support compared to only 65% in the conventional ratio protocol, and only 6.9% of the TEG based patients had coagulopathy compared to 31% in your ratio based protocol. So there was also a 10% reduction in mortality in the patients who were given TEG guided transfusions. So they concluded that TEG guided goal based approach helped to reduce the blood component utilization with a reduced incidence of coagulopathy at the end of massive transfusion while improving the patient survival. So this was the group A and group B they recruited. You can see at the end that there were about 51 patients with trauma. These are RTA cases which were included in group B. There were 24 cases of UGI bleeds. There were 14 cases of PPH, 14 surgical cases, 6 other cases that also included snake bite, etc. Then this was the tech-based algorithm that they have followed. So when MTP was activated, we used to give the PAC1, that is 2 units of O negative PRBC or O positive if it is not a female within the childbearing age group, and or ABO compatible PRBC and 2 ABFFP. Again, so your ABG, CBC, PT, APTT, TEG, blood grouping, and cross matching is sent at this level. Based on one set of investigations, PAC2 series is given. Again, based on the second set of investigations, PAC3 series is given in this manner. So summarizing my PPT, activate MTP early. Don't wait for lab confirmation. Clinical diagnosis is more important. Don't transfuse blindly. So your fixed ratios are a starting point. They're not the end goal. Use goal-directed strategy, whether it is ROTEM or TEC. It identifies the exact deficit, and you can only treat that. So treat in order as we've discussed. So when we diagnose, it's in ulta order. It's factor deficiency first, then low clot strength, then your fibrinogen, then hypofibrinolysis. But treat in the reverse order. Treat your hypofibrinolysis first with tranexamic acid, low fibrinogen with cryofibrinogen, low clot strength with platelets, and factor deficiency with plasma or PCC. And combine approaches. Start with massive transfusion protocol, ratio based, and shift to a targeted therapy. Always send conventional tests also alongside so that the right product reaches the right patient at the right time. Thank you. I think I'm done. If there are any questions or
Uh, Thank you, ma'am. That was a very insightful session. Actually, ROTEM or TEG was previously utilized in the 1970s, but then it had died off late, and it was only limited to cardiac ICUs or CTVS surgeries. But of late, we are seeing that there is a use case in emergency department, since it's a point of care test and it can be read by an emergency physician or by a transfusion medicine physician within 15 minutes, and it is helping us to direct our transfusion protocols. So, any questions, any doubts, we can address. So, I don't think there are any doubts, so we can conclude this session. Thank you, ma'am, for this the well-designed session. It has included everything that a ER physician needs to know about goal-directed massive transfusion, and we would like to implement it in our centers, and we would appreciate if other centers also can implement it in their centers as feasible.
Yeah, we are actually
Uh,
getting ROTEM, so I think once ROTEM validation is done, we can
yeah,
probably
that would
collaborate on
be,
that. It's easier.
yeah, we can collaborate on that. Yeah.
Yeah.
At the end, I would like to thank Yashoda Hospitals for giving us this platform where we could discuss topics every Friday with experts in their fields. I would also like to thank uh, our organizing chairperson, Dr. Srinath, Group Head and HOD of Emergency Department, Yashoda Hospitals. Our other organizing co-chairperson, Dr. Tejaswi, Senior Consultant, HOD, Department of Emergency Medicine in Yashoda Hospital, High Tech City, and Dr. Shravani, Senior Consultant and Clinical Head, Department of Emergency Medicine in Yashoda Somachiguda. Dr. Malay Mishra, HOD in Emergency Department in Yashoda Secunderabad, and Dr. Sai Kiran, HOD of Emergency Department in Yashoda Hospitals, Malakpet. Uh, every Friday, we will bring more interesting and relevant up-to-date topics in emergency medicine presented by our experts. So that's it for today, and we can meet coming Friday with another interesting topic. Thank you.